Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient initially saw a different doctor who tried to perform a lens refixation of this dislocated IOL. And this patient came to see me, and the lens was very dislocated still. And so I went ahead and did a Yamane technique, my modified technique for being able to perform intrascleral haptic needle fixation of this Allergan SI30 lens. So as I've shown in my previous videos, the Allergan SI30 IOL has polypropylene haptics, and I've discovered through refixating these lenses using my modified Yamane technique, these haptics are very strong, almost similar to the CT Lucia polyvinylidene fluoride haptics. And so you're going to see this lens, and this is very interesting and tenuously held lens. As you can see here, this is the case. You can see these characteristic round circles of the blue haptic material, again, polypropylene, and this is the characteristic design of these SI30 IOL haptics. So I'm going to go ahead and place my marks, and this is the epsilon 2.5 and 2.0 fixed calipers. So I go ahead and I mark 2.5 millimeters back and then 2 millimeters adjacent, and then using a cannula that's already been marked, I'm finding 180 degrees apart and then marking the limbus with that cannula. Again, the cannula tip is marked so it gets a really nice and tight little mark on the limbus. And so you can see here, this is the fixed caliper that I got from epsilon 2.5 millimeters on one end and 2 millimeters on the other end. Again, you know I prefer to go 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent, and I always target about a -1 on my lens. So go ahead, I go back radial, again, 2.5 millimeters back, and then 2 millimeters adjacent. And you need those landmarks in order to execute the surgery. And so I make a paracentesis incision, contra-incisional and perpendicular to my limbal marks, and then I make another paracentesis incision on the right and then left sides, and I need those incisions to help manipulate that lens. This is intracameral Kenalog that's been washed, and I put that in there to see if I see any vitreous. And the good news is I see no vitreous whatsoever. Again, this patient already had a vitrectomy and attempt at refixation by another surgeon. So I think the vitrectomy was done adequately. This is a 3.0 millimeter keratome diamond blade, and this is a 25 gauge needle. I'm bending it, and I'm bending it pretty close to the tip, and that's because it doesn't have to be bent too far back. And you want the bevel facing to the right. That's a 25 gauge needle, which will help me externalize the leading haptic. And this is the 30 gauge thin wall TSK needle. And this is the right side needle. I'm bending about 9 millimeters back from the tip. Again, the bevel faces towards me for the right side needle. And about 70 to 80 degrees. And now this is the left side needle. I'm bending at the hub, and the needle bevel is facing away from me. Very important details when you're trying to execute the technique. Now I'm using 2 MST microforceps. I'm going to try, look what I've noticed. The haptics are upside down. And so now I'm going to have to rotate the haptics, and I did a little pivot movement. Again, this is a little tenuously held in the vitreous space. I don't know how it is because I don't really see anything. So I went ahead and flipped the lens 180 degrees. Luckily, I have one of the haptics in the anterior chamber. And then now I'm doing that docking technique, docking the leading haptic on the bevel of the needle of the 25 gauge needle, externalizing it. By doing it this way, you're not going to damage the tip of the haptic because you're passively docking it on the bevel of the needle. And now with 2 microforceps, I'm going to very carefully try to lift that trailing haptic up into the anterior chamber, and then very carefully externalize that trailing haptic. Pushing some viscoelastic, dispersive viscoelastic to fill the chamber and to push that lens back. And now this is a paracentesis incision for my 20 gauge Lewicki AC maintainer. And you need AC maintainer for good infusion pressure. You need a solid eyeball if you want to do the scleral fixation with the needle. So I hold the eye with forceps at the level of the incision, and this is the right side needle. I'm piercing the sclera at the first mark, tunneling 2 millimeters, and then diving down. You want to go straight back towards the nerve, and you don't want to rotate too soon because you don't want to hit the ciliary body. You can see now through the pupil that the bevel is facing towards me, and it's important for it to be facing that way because within the same plane, I'm going to be able to dock the haptic on the bevel of the needle, the trailing haptic. Again, these are polypropylene haptics. They're quite sturdy, as you're going to see here, and I'm able to place that haptic into the eye. And because I've externalized the leading haptic, it's very easy for me to visualize and go ahead and dock the haptic on the bevel of the needle, flatten it out, and then cannulate that needle with the technique. The bevel is facing towards me. The haptic is actually pointed towards the bevel. I'm able to cannulate it very easily and confidently. I disengage the syringe from the needle. And then lay it down. And then I'm going to internalize the leading haptic and then lay it into the angle. And now I'm in a stable situation. I go ahead and go with the left side needle. Again, the bevel is bent at the hub and the bevel is going to face away from me. I'm holding the incision in this case. Again, I don't have trocars because this patient already had a vitrectomy. I place the needle at the first mark, tunnel 2 millimeters, and then dive down and then rotate. And so as I rotate, you can see the needle now. Now this was a challenge, and I'm going to tell you, I should have and could have put some iris hooks to retract the pupillary edge, because you can see with all that manipulation and flipping that lens, the pupil started to shrink. And so I thought to myself, you know, this is not a PMMA haptic, it's polypropylene, they're pretty strong. The only thing I can't do is lose my grip. So I'm just trying to be very careful, making sure I'm straight on with my needle and haptic. I'm not quite sure. I go to higher mag, making sure I dock that haptic on that's so important. So now that I've docked it finally, and I'm able to feel that it's going in, I'm very carefully threading the haptic into the needle. And I'm pulling the needles on both sides because I want to make sure the optic is still centered as I pull equally on both sides. The left side pointed towards me and the right needle pointed away. Again, as the needle is pulled out, I want to make sure that the haptic is not pulled out too much out of the eye. Cauterize the tip. It was a tiny bulb, so I'll go ahead and cauterize it a little bit more, and that's good. Go ahead and still have my microforceps in my left hand, pulling the needle away from me and making sure I grasp the haptic so it doesn't slip back in, just in case. Get a nice grip on the haptic, cauterize the tip, and then I internalize the length of the haptic and make sure the bulb is pushed flush to the sclera and reapproximate the conjunctiva. So as you can see here, this lens is well centered. Again, this was a shrinking pupil. Again, because I flipped that lens, it was upside down. In the process of flipping that lens, it touched the iris, of course, and it must have caused that pupil to shrink. Again, it was a little bit dicey going after that leading haptic, but because of the polypropylene strong haptics, I felt confident that I can still do it. And again, the concept of docking the haptic on the bevel of the needle, I used to my advantage. As you can see, I put a tendonylon suture to the main incision. I always do this for these lens exchanges, complicated techniques when you could encounter vitreous. And this is the surgical PI technique where I have a low flow setting. I'm able to perform a temporal and peripheral, very well positioned and sized, small size peripheral iridectomy. And then I switch to anterior vitrectomy, making sure I remove any potential vitreous, as well as removing the viscoelastic from the anterior chamber. As you can see here, I'm retracting the pupil with the Maltman. As you can see, the lens is nice and well centered, and I'm performing vitrectomy as I retract the pupil, one, to protect the pupil with the Maltman from the vitrector, but also to be able to make sure I get a good vitrectomy around that pupillary area. because you don't want any vitreous coming around anterior. So I'll go ahead and switch sides and do the same thing, again using the Maltzman to retract the pupillary edge and also performing vitrectomy in that area again. Come out and then filling the eye with BSS as I come out with the vitrector, hydrate my incisions. I'll take the AC maintainer out, and then that will be the end of the case. You'll see I'll put some subconj, lidocaine, Kenalog, and NSAF at the end. So again, this patient had a dislocated SI30 Allergan lens. It has a characteristic circles at the optic-haptic junction. This patient had an attempt at refixation somewhere else and came now afterward to see me with a dislocated lens. Not only was it dislocated, it was upside down. I don't know if the original surgeon put it upside down or if the refixating surgeon put it upside down. Nonetheless, you saw that there was essentially no capsule support, which was really mind-blowing. And I see this a lot in these kind of cases. And I think it kind of explains the late dislocation phenomenon on some of these cases. I think as the vitreous changes over time and becomes more liquefied, the lens dislocates, and that's where the dislocation manifests so many years after the fact. So again, it's surprising with a tenuous support within the sulcus or within the bag, a lens can actually be pretty stable for quite some time. But you saw I used a one-handed maneuver to flip that lens over, externalize the leading haptic using a passive externalizing technique using a 25 gauge docking technique. By externalizing the leading haptic, I was able to very easily and efficiently cannulate the trailing haptic through the right side needle, again using the docking technique, being strategic about bending the needles in a certain way, making sure my marks are really nice and symmetric, and then holding the eye in the neutral position as I place the needles through the sclera and dive into the eye. So important that the marks reflect where you want it to be, and the only way to do that is to make sure you hold the eye in the neutral position. If you let the eye move around, the marks that you initially made will not end up where you intended for them to be. And so this is how I perform my modified Yamane technique. Again, quite a bit of a different technique than his original technique, and I believe this technique will allow you not only to perform this technique with the CT Lucia lens, but also with this SI30 lens, but even with lenses that have the delicate PMMA haptics such as the J&J Sensor and Technis. Again, the SI30 lens, if you ever see it dislocated, don't throw it away. Don't cut it out. You can use this lens and you're able to refixate this lens because of the polypropylene haptics, and it works very, very well, as you can see in this case. So I hope this was helpful to you, and I thank you for your attention.